All right, well, good evening, everyone, and I wanted to welcome you all to this year's Nebraska Oncology Society's Evening Speaker Series. So before COVID, the Nebraska Oncology Society would host these types of events pretty regularly to discuss different topics in oncology. And because of the pandemic, we've been able to pivot to a virtual setting. And so for tonight's fourth topic of the series, we have gynecologic oncology. Here is our agenda for tonight's event. I want to thank the exhibitors for tonight and encourage you all to please visit their virtual booths on the virtual platform. So with this format, I just want to go over a few housekeeping items. First, as we are using Zoom, you can find all of your webinar controls by hovering over the edge of the Zoom screen. You'll find your microphone, webcam, and chat box options, among other things. So please make sure that your microphones are muted throughout the meeting. If you need to ask questions, please use the chat box or wait until the Q&A portion of the session to unmute yourself and ask your question. We'll address all questions at the end of the presentation. You can also use the chat function to send messages privately to individual attendees. If you're having technical difficulties, please close your browser and use the link to access the webinar once more. Otherwise, feel free to send me a message via email and we'll try to troubleshoot. The presentation is being recorded and will be uploaded to our event website. We do encourage to use the webcams if you're able to, in order to help have a more face-to-face atmosphere with the event. I also wanted to remind you to use the virtual platform to visit our exhibitor booths. You can chat with the company representatives live. So make sure that you are able to take advantage of that opportunity and thank them for their participation. Without their support, the Nebraska Oncology Society would not be able to carry out its mission of enhancing patient care through oncology research, education, and healthcare legislation. We also encourage you to participate in our competition. Each exhibitor booth has a unique competition code located somewhere on their virtual booth. If you're able to find 7 of these codes and email them to me before the end of the day, you will be in the running to win a $100 Amazon gift card. We do have a CME available for this event, and you can complete the evaluation on event homepage. The evaluation will be live tomorrow. And now I want to introduce our speaker, Dr. Lan Kaufman. Dr. Kaufman specializes in medical oncology and hematology oncology. She completed her medical degree in Wake Forest School of Medicine, followed by her residency and fellowship at the University of Michigan Health System. Her research focuses on ovarian cancer microenvironment, understanding and targeting the cancer-supporting stromal tissues, which are critical to the survival, growth, and spread of ovarian cancer. Specifically, Dr. Kaufman studies a critical non-malignant component of the ovarian cancer microenvironment, the carcinoma-associated mesenchymal stem cell, CAMSC. She demonstrated that CAMSCs form a critical BMP4 hedgehog signaling loop with ovarian cancer cells. Blocking this loop with a hedgehog inhibitor prevents CAMSC-mediated tumor growth, enhancement of cancer stem-like cells, and chemotherapy resistance. Dr. Kaufman also studies how CAMSCs impact the development of ovarian cancer metastases and the metastatic microenvironment. The ultimate goal of her research is to translate novel laboratory findings into powerful therapeutic approaches for the prevention and treatment of ovarian cancer. Thank you for joining us today, Dr. Kaufman.
Thanks for having me. Are you ready for me to start? Great. All right, let me share my screen here. All right, can everyone see my screen okay?
Yes, we can.
All right, fantastic. And I should hopefully be able to see at least the chat function. So if there are questions that come up, please feel free to interrupt. I'm happy to be as informal as possible. I'm really putting my clinical hat on today, and we're going to talk about kind of standard of care and up and coming therapies in gynecologic cancer. Not going to talk about my basic research today. If anyone has questions, I'm happy to discuss that at the end. I am a medical oncologist, but I specialize in gynecologic cancer. So largely ovary cancer, which is my research interest, but also, the other spectrums. So endometrial and cervix, and some sarcomas and vaginal vulvar. But I'm going to focus today on ovary, endometrial, and cervical cancer. As a disclosure, so I have served as a one-time consultant for ImmunoGen, who makes mirvetuximab, which is a up-and-coming therapy that I will discuss today. I have no ongoing relationship with them. So as I mentioned, really going to focus on ovary, endometrial, and cervical cancer. I'm going to largely focus on kind of the newer therapies. PARP inhibitors really have revolutionized ovarian cancer treatment, and the landscape gets more and more complex. So I'll spend a fair amount of time trying to unravel the data behind PARP inhibitors, and then talk about some of the new antibody drug conjugates and immunotherapy kind of heading our way. And then pivoted to endometrial cancer and the strides we're making largely with immunotherapy in that disease. And then cervical cancer, which again, we're largely seeing strides in the immunotherapy world, which is quite promising. Okay, so let's start with ovary cancer. Pretty common knowledge that this is a bad disease, largely because we catch it at late stages. The incidence to mortality ratio is quite high, and our 5-year survival is still under 50%. So an area of certainly ongoing research and clinical needs. Just as an overview, because not always, but particularly as medical oncologists, we don't get to see gynecologic cancers all that often. So, ovary cancer, the vast majority are epithelial, and that's what I'm going to talk about today. I'm not going to talk about germ cell tumors, stromal tumors, or kind of any of the other kind of funky pathologies. We're really going to focus on the common epithelial cancers. Also important to know, when we talk about ovary cancer, we're really talking about ovarian, primary peritoneal, and fallopian tube cancers. They're really all the same disease, and they're treated the same way. We've largely broken ovary cancer into kind of two types based on their genetic features. Type 1 are the less common. So about 30% of epithelial ovarian cancers fall into this type 1 group. And those are histologies like endometrioid, clear cell, low-grade serous, mucinous. They don't have p53 mutations. They tend to look a little more like endometrial cancer or colon cancer, p10 mutations, KRAS mutations. And they are thought, some of them are thought to arise in sites of endometriosis, versus the type 2 cancers, which is really the vast majority of these cancers. They are high-grade serous. These are the cancers associated with BRCA mutations. They're almost universally p53 mutated. And this is where really the advent of PARP inhibitors have made a large impact. Interestingly, the cell of origin for high-grade serous ovarian cancer is actually likely to be the distal fimbriated end of the fallopian tube. So it's a bit of a misnomer to call it ovary cancer. There is a precursor lesion called a STIC, which is a serous tubal intraepithelial carcinoma that arises in the tube. And actually the ovary seems to be the first site of metastasis. So as we talk about things like early detection, it is really hard in these cancers because they start at these tiny little proliferations in the fallopian tube and are already metastasizing when they're going to the ovary. One thing to know about ovarian cancer: any woman with ovarian cancer needs genetic testing, both for themselves and to help guide therapy for family. And that's because the prevalence of BRCA mutations are quite common. So about 17% of women will have a germline BRCA1 or BRCA2 mutation. Interestingly, about another kind of 35 to 40% will have a mutation that leads that cancer to be homologous recombination deficient. And that's important because with the advent of PARP inhibitors, this is actually highly predictive of response, so helps guide women's treatment. So these women need genetic testing to help understand if their family is at risk and allow for cascade testing. But somatic testing is also really important to help guide their own individual treatment. So when you think of ovarian cancer, think of genetic testing. I put this in just to kind of get a feel for how treatment options have changed in ovary cancer over time. You know, for a very long time, we were playing with different chemotherapies. And then we start to see the advent of bevacizumab. PARP therapy started in 2014. We have this one incidence of HIPEC. I'd say it's really PARP throughout and ongoing is making the most impact in ovarian cancer treatments. So I provide this just as a big picture overview, not meaning to go through the entire history of ovarian cancer treatments or what's available, but really this is a summary of initial treatment options. So the vast majority of women will undergo debulking surgery either upfront or after neoadjuvant chemotherapy. We have non-inferiority data here. Oh, maybe you can see it here. There's also different ways to give platinum-based therapy, traditional Q3 weeks, 6 cycles, IP chemotherapy, dose dense. There's also bevacizumab maintenance. I'm really not going to touch a lot on Bev today. I'm going to talk a little more about HIPEC because the Bev data is a bit, or PARP, because the Bev data is a bit older. But there is some debate in terms of when you use it and if you use it upfront. Newer data on HIPEC and on PARP maintenance, and that's really what I'm going to focus on here. So also in recurrent disease, really it's based on platinum sensitivity, which means the time from to recurrence from last platinum. So if it's greater than 6 months, patients are deemed platinum sensitive and they get retreated with platinum as their standard of care. And then platinum resistant disease, recurrence less than 6 months. You're really talking about palliative single agent chemotherapies, plus or minus the addition of bevacizumab. Okay, so I'm going to briefly talk about HIPEC because I don't think we get to see this very often unless your institution has surgeons that specialize in this, and not many do. But HIPEC is heated intraperitoneal chemotherapy. And this is a landmark study from 2018 in the New England Journal of Medicine, which took stage 3 ovarian cancers. They basically started with a neoadjuvant approach. So they got 3 cycles of carboplatin Taxol chemotherapy. If they had stable disease or better, they were randomized to either debulking surgery and HIPEC. So HIPEC is done obviously in the OR. So you optimally debulk and then you infuse this hot chemotherapy and it dwells in the belly for a couple hours and then you drain it out. So it's a very long surgical procedure versus just standard debulking surgery. And then everyone got adjuvant carbotaxol on the back end. Recurrence-free survival and overall survival. So recurrence-free survival is about 3 months difference. I think that the biggest, practice-changing data here is the overall survival benefit of, about 12 months. So this curve separation certainly is an argument for HIPEC. You will see that there's no maintenance therapy here. So there's no bevacizumab added, there's no PARP added. But if we're just talking about chemotherapy, this is something that is certainly an option. I think the biggest drawback here is you need a surgical team that's specialized in doing this. This can be really toxic. So you need a team that knows what they're doing. And so it's not available to everybody. And so I think there has been not a lot of uptake in HIPEC because of that, but certainly something to keep in mind, and probably something we'll have ongoing studies in. Right, now I want to shift to PARP because I do think this has been the game changer in ovary cancer and will continue to be. So PARPs take advantage of a concept of synthetic lethality. So PARP is a protein that is important in repairing single-strand DNA breaks. And so when PARP is there, all these DNA breaks that our body is bombarded with get repaired easily. When you inhibit PARP, you can't repair these single-stranded breaks, which then get converted to double-stranded breaks. In a normal cell, that's fine. You have methods to repair double-stranded DNA break. The most accurate way is using homologous recombination. And so you repair your break and you're fine. The problem becomes, when you have a cell that's deficient in homologous recombination. So best known for cells that have BRCA mutations, which are key proteins in homologous recombination. You can't actually repair these double-stranded breaks, and you get overwhelming DNA damage and the cells die. And so that is the concept behind synthetic lethality in ovarian cancer, which has about 50% of patients have homologous recombination deficiency, whether it's from BRCA or something else. So we have had kind of an avalanche of approvals of PARP inhibitors. There are 3 PARP inhibitors that are approved in ovarian cancer: olaparib, rucaparib, and niraparib. I will say their efficacy is quite similar. It's very much a class effect. There are some differences in toxicity, but the drugs are pretty similar. Walk through what their indications are. So like most drugs, when they first came out, they were studied in the heavily pretreated population. So they were initially studied as single agents in recurrent metastatic disease. That's where olaparib got its first approval in 2014, and then rucaparib and niraparib later. I will mention that rucaparib has actually is planning to pull this indication, and I'll go into that data a little bit later based on some overall survival data that is coming out. So after this, I started using these drugs as recurrent platinum-sensitive maintenance, and this is where I think we're most familiar with PARPs. All 3 drugs are approved in this setting, and so this is ovarian cancer that's come back. It's platinum sensitive. They are treated with a platinum agent, have a partial response or better, and then they go on to PARP maintenance. And then more recently, it's been moved earlier into adjuvant maintenance, and olaparib and niraparib, and then olaparib plus bevacizumab are approved in this setting. So upfront, have their surgery, have their chemotherapy, and then have a PARP inhibitor, generally for about 2 years. And then most recently, rucaparib has joined this indication in the adjuvant setting. The Athena trial was just presented at ASCO, and they've submitted for FDA approval, and I'll walk you through that data. But again, the indications are very similar for all 3 drugs. So let's go through some of the data. So again, this is Athena, and I just chose this one because it's most recent. The data is remarkably similar for all 3 drugs. So this is a randomized phase 3 using rucaparib as maintenance therapy in upfront women with ovarian cancer. So this was an all-comers trial. Because it's always a question, which patients do you give this to? Is it just those that are BRCA positive or homologous recombination deficient? This had all comers, and then they analyzed the intention to treat analysis, and then they had subgroups that were HRD positive and broke that down by BRCA mutation status. So this is PFS, and the trial was powered for PFS. You see a significant improvement in PFS, and we see this kind of across the board, about a 10-month improvement. And then when you look specifically at the HRD population, you'll notice that these women do better in general, but the impact of PARP is greater in this subset. Interestingly, I think this is the group that is the biggest question. These women that do not have homologous recombination deficiency, right? So they're BRCA wild type, they're not HRD. They have a benefit, but it's much more modest, right? This is a 3-month benefit. And so the question is, in the adjuvant setting, is 3 months improved PFS worth 2 years of maintenance therapy? And the toxicities that go along with PARP, which are largely myelosuppression, some fatigue, some nausea, and there is about a 1% risk of leukemic transformation, because this is something that induces more DNA damage. So I think this is an ongoing debate about is it worth it to give PARPs in this setting? Okay, so moving into the next indication, so in the recurrent platinum sensitive, again, this is where I think most people are very comfortable using PARPs. So maintenance therapy after you're giving them their platinum therapy again, we see a huge separation in the PFS curves. This is with olaparib versus placebo. Again, very similar curves with our other PARPs. And this is just to compare them. So olaparib, niraparib, rucaparib, all in the same setting. The patients are different. So what I just showed you was germline BRCA. And so they do the best with PARP. And you see this dramatic improvement in PFS. And then with niraparib, you see the same thing with the germline BRCA. Again, that starts to dip down when you're not germline BRCA, and particularly in those women that do not have homologous recombination deficiency. Again, about a 3-month difference. Rucaparib is very similar. And so there has been some update in overall survival. I want to emphasize that these trials have been powered for PFS. That's their primary endpoint. So overall survival is a secondary endpoint, but still important to look at. And so olaparib didn't quite make the 0.05 cutoff, although one could argue that there's clinically a significant benefit in the difference in OS here. Of note, there's a lot of crossover in these patients. Those that didn't get PARP on trial, a lot of them got PARP afterwards. The niraparib data is interesting. The magnitude of survival benefit is a little bit less in the BRCA germline group. I think what was raising some concern in the gynec community is this. The overall survival is actually looks like it may be detrimental in the non-germline BRCA mutated patients. In that, again, this is not powered for OS, but it's a little concerning to see a trend in survival that goes the other way. And so this warrants a lot more study. And is raising some eyebrows in terms of we need to be thoughtful about what's happening after we give this maintenance therapy. And then PARP is monotherapy in either platinum resistant or platinum sensitive. The later you give PARP, the less effective it is, but that is true for all our anti-cancer therapies. Still seeing improved response rates, PFS. Solo 3, there was no survival, overall survival benefit. And then for Aerial 4 with rucaparib, this just came out. So there was a very modest PFS benefit. but they just published their interim overall survival data, and similarly there's a trend towards detriment here. And so I mentioned that rucaparib was planning on pulling their FDA indication for this indication as a single agent, and that's really based on this survival data. So I think there's a lot more work we need to do to understand the overall survival differences in PARP inhibitors. Okay, and this is just to show that really the benefit is largely in women that have BRCA mutations or HRD. These HRD negative, which sign it kind of equivalent to HRP. I won't get into the details of that, that's confusing. But non-HRD benefit is very, very modest in this as a single agent, kind of late into treatment. Okay, so again, lots of PARP trials. And if PARP works by itself, does it work better combining with other things? There are ongoing trials to see if we can enhance response and prevent resistance. So combining PARP with immunotherapy, combining PARP with anti-angiogenic factors. There's some data with PARP and BEV, but there are a lot of ongoing trials here. PARP with BET inhibitors to try and reverse resistance. So then we're going to continue to hear about PARPs in the future. So I want to shift gears a little bit and talk more about antibody drug conjugates. Now, these aren't FDA approved yet, but there is mounting data here. And so an antibody drug conjugate is kind of like a Trojan horse. So you have an antibody that's specific for some antigen expressed on a tumor cell. And it's linked with a poison. And so the antibody directs that poison to the cancer cell. It gets taken up and releases the poison, and that way kills the cancer cell. At least that's the concept behind it. So couple of antibody drug conjugates that are on the horizon in ovary cancer. Mirvetuximab probably has the strongest data thus far. Just presented the SORAYA trial at SGO and at ASCO. And this is an antibody drug conjugate that targets the folate receptor alpha on ovarian cancer cells. And so this was in a group of pretty heavily pretreated platinum-resistant ovary cancer that had high expression of folate alpha, which is about 30% of patients. It was a single-arm phase 3. And in this patient population, there was an overall response rate of about 32%. And when we talk about platinum-resistant disease and things like standard chemotherapy, response rates are generally in about 20% range. So seeing a response rate of 32% was pretty encouraging. And so there are a lot of ongoing trials with mirvetuximab in different settings. So Mirasol is in platinum-sensitive disease in combination with chemotherapy. We also are using it, this is platinum sensitive. Another one with carbo is neoadjuvant, and then in combination with BEV. So we're going to see, I think, a lot more of mirvetuximab, and I believe they've already filed for to the FDA for initial approval. So interesting to see if this will get approved. I think the caveat is these women have to express folate receptor alpha, but it would be an interesting addition to our therapeutic options. Another antibody drug conjugate on the horizon is this upifitamab. I think that's how you pronounce it. I really only know it by its trial, which is called Uplift. But it's an antibody drug conjugate that targets a sodium receptor. And it was also studied in platinum-resistant disease. It's actively enrolling, so this was just kind of an interim analysis presented at ASCO last year, but a very similar response rate. So again, pretty encouraging. And they're also looking at this antibody drug conjugate in lots of different settings in ovary cancer. So these two, I think, are on the horizon and something to look out for. Overall, well tolerated. much less things like myelosuppression and nausea. They have a unique ocular toxicity. So there's a lot of monitoring with ophthalmology, a lot of eye drops and things. More conjunctivitis, but there is something about a lot of antibody drug conjugates that have this kind of unique tropism for the eye. So I think that's something as oncologists that we will have to learn how to manage. Okay, and then everyone always asks about immunotherapy. So immunotherapy in ovary cancer has been, or at least the immunotherapy that we have thus far has been pretty disappointing. So we generally think of checkpoint inhibitors, and so have had a lot of trials of checkpoint inhibitors in ovary cancer, and they just don't work well. Right? We're talking about response rates in the like 10 to 17% range, and generally not durable. So the microenvironment of ovary cancer is pretty cold, and we haven't found great ways to enhance the immune response. So single agent checkpoint inhibition is not approved, not a great option in ovary cancer. Hopefully we will be able to augment that with other agents to have an immunotherapy option. We just don't have it yet. I did want to bring up this antibody which targets CA125. So CA125 is our main tumor marker for ovary cancer. There is some encouraging initial data, phase 2 data for this antibody in combination with chemotherapy in upfront ovarian cancer. Seeing a relatively good separation here. Again, this is just very early data, but this is an ongoing trial, one in which immunotherapy may be having an effect. We'll have to wait for the final data here. They're still actively accruing, so we will see. But it makes logical sense to have an antibody to the main marker in ovarian cancer. So we'll stay tuned for that one. All right, I'm going to shift gears and move on to endometrial cancer. And again, if there are any questions, feel free to put them in the chat, or I'm happy to answer them afterwards. Endometrial cancer, we generally think of this as a cancer where women do well. And that's largely because, it generally presents early and we can resect it and resect it for cure. There is a bit of an alarming trend, which is not necessarily captured here, maybe a little bit, in increasing incidence and actually mortality in endometrial cancer. There are a lot of racial disparities here as well. So worse outcomes in African-American women. And we're seeing more of these high-risk histologies that I'll go into a little bit. So I think endometrial cancer is something that we need to focus on more. And this goes beyond just an obesity-driven increase in endometrial cancer. So let's talk a little bit standard of care. So for a long time, we've been characterizing endometrial cancers kind of similar to ovary, with a type 1 and a type 2. Now, I don't know why okay, so type 1 is like type 1 in ovary. These are endometrioid histologies. They have their P53 wild type. They have PTEN mutations, PI3 kinase mutations, and these are the most common. So it's kind of flipped from ovary. So about 70% of women present with these type 1 endometrioid cancers. The type 2s are our high-risk histology, and these look a lot more like high-grade serous ovarian cancer. So high-grade serous fall in here, clear cell carcinosarcs fall in here too, and about 30% of women have these type 2 histologies. The way we're classifying endometrial cancer is changing, and I'll go into that in a minute. But basically, standard of care is obviously stage-based. Surgery is the mainstay, and then we talk about adjuvant therapy. And so, observation versus radiation. Radiation in stage 2. Stage 3, we're talking about chemoradiation. Chemotherapy is platinum-based therapy. And then stage 4 is palliative chemotherapy. And really the only difference in these high-risk histologies is that pretty much everybody gets adjuvant therapy, both chemotherapy and radiation. And then for recurrence, if there's localized recurrence, particularly at the vaginal cuff, these can be cured with resection or radiation. If it's diffuse with multiple sites, you have to look to see if it's a low grade kind of endometrioid histology, use hormonal therapy. If not, we are left with chemotherapy. But over the last few years, we've seen really kind of game-changing improvements with checkpoint inhibition and this combination of Lenvima and pembrolizumab. And so I'll go into that and in which patients. But it's really based on this mismatch repair deficient phenotype. So about 30% of endometrial cancer is associated with mismatch repair deficiency, and about 5% of that is Lynch syndrome. So, right, Lynch syndrome is our inherited mutation in one of these mismatch repair proteins. So it's a germline mutation. Interestingly, the incidence of colon cancer with Lynch is virtually the same with endometrial cancer. So we think Lynch, should think of endometrial cancer just as much as colon cancer. And all of these patients on their resection specimens should be having immunohistochemistry or some sort of screening for mismatch repair deficiency. To understand kind of what this is, right? Kind of similar to the single strand breaks I was talking about before in ovary. You can also get just mismatch inaccuracies that another type of DNA repair is important for. If you don't repair it, you're at risk for developing cancer. And that's really the basis behind developing endometrial or colon cancer in Lynch syndrome. But interestingly, when you have this mismatch repair deficiency and you develop cancer, you actually create kind of an immune hot signature. So you have all of these DNA damaged proteins, and so you get a lot of these neoantigens, and so the immune system is more able to recognize that. And so it turns out that these mismatch repair deficient cancers are much more responsive to immunotherapy. And I think, we all know that. We know that there's a pan approval for mismatch repair deficient tumors for checkpoint inhibition. And so that's clearly important in endometrial cancer. So this is a follow-up from the initial KEYNOTE study in a cohort of just mismatch repair endometrial cancers. I should also note, mismatch repair and microsatellite instability are virtually synonymous, and either one of them will tell you that you're responsive to immunotherapy. So these are women that had recurrent cancer, had chemotherapy, disease grew, and were treated with pembrolizumab, and a pretty impressive response rate of about 50%. And you see that this is the durability of the response. So that's what we want to see with immunotherapy, right? We're not only getting a response, it looks like it's durable. So really, this has been a game changer for mismatch repair deficient endometrial cancer. But 70% of women are mismatch repair proficient. So what about them? So this is also a landmark study in endometrial cancer. And so this was in all comers, but enriched in these mismatch repair proficient cancers. So about 700 of them, about 130 were mismatch repair deficient. And they were randomized to chemotherapy or lenvatinib, which is a tyrosine kinase inhibitor, in combination with pembrolizumab. And you see a modest improvement in progression-free survival. But what's really striking is the overall survival benefit. So, about a 7-month improvement in overall survival in all comers. about a 5-month improvement in this mismatch repair proficient group. And again, fairly heavily pretreated, at least had already progressed through chemotherapy. And so this has changed the standard of care in endometrial cancer. I don't think I put this in here, but response rates were actually close to the 40% mark. So this really is moving into rapidly moving into standard of care, and we're also having ongoing trials to see if we can move this earlier into our therapy rather than having to use it after chemotherapy. So I mentioned that the way we classify endometrial cancer is changing, and it's really based on this. So this is data from TCGA from 2013. And we've been focusing a lot on this subgroup, this mismatch repair deficient or microsatellite unstable or instability group. And so we know that that is predictive of response. What this paper did was show that these 4 subgroups, so this is POL-E, it's a mutation in a DNA repair enzyme, and if it's mutated, you have these ultra mutations in the DNA. And actually, these women do exceptionally well. So that's this blue curve here. Probably because their immune system recognizes them because they have so many neoantigens. And then you have the mismatch repair deficient, which is in green. And then you have your copy number low. These are the mismatch repair proficient, and what we would have initially called a type 1 endometrioid cancer. And these copy number high are the ones that we would have initially called a type 2 kind of high risk or serous-like cancer. And they call them copy number high. That's just something that's a hallmark of serous cancers. They're also p53 mutated. And these groups are prognostic. These guys do the worst. And so these molecular subgroups are really changing how we are understanding endometrial cancer. It's becoming pretty standard to do mismatch repair deficiency staining upfront, so we can at least identify this subgroup. There is an ongoing push to say, should we be doing POL-E sequencing, and should we be identifying this group of folks either through a p53 stain to be able to really tease out these subgroups. Since we know they're prognostic, we know this group is predictive of response to immunotherapy. And so ongoing trials are taking advantage of this. So this is the TransPortec Rainbow Umbrella trial for endometrial cancers, and they are all classed based on these subgroups. And so again, you have our mismatch repair deficient, you have your POL-E mutated. NSMP means no specific molecular profile, but this would be that copy number low type 1 endometrioid group. And then this would be our copy number high serous p53 mutated group. And you can see what we're trying is different in each group. So in the ones that look like serous cancer, it's chemoradiation versus chemoradiation and a DNA damaging agent like a PARP. That makes sense, right? In the mismatch repair deficient group, we're looking for immunotherapy. In this POL-E mutated group, because they do so well, we're looking actually to de-escalate. So I think knowing these subgroups is really going to change how we understand how we are testing and how we're treating endometrial cancer. And then I want to end by looking at cervical cancer. I think this is a cancer that has traditionally been understudied. It's a tough cancer because we have vaccinations to hopefully prevent, and I'm going to give my plug for that in a minute. We have screening to hopefully catch early, and those certainly make an impact. But when we don't catch this early, when this comes back, when cervical cancer metastasizes, our treatments are really awful. They're pretty miserable. So that is certainly an unmet need. And so it's nice to see at least some movement in this area. So brief standard of care, again, early stage, we cut it out or use chemo radiation. If it's metastasized, standard of care is cis-taxol bevacizumab. Now with a new addition of adding pembrolizumab, and I'll show you that data, local recurrence, our really only option for cure is exenteration, which means taking all the pelvic organs out. If it's a distant recurrence, we're talking about palliative chemotherapy. We talk about single agent pembro and the antibody drug conjugate, which is actually approved in this disease, tisotumab vedotin, which everyone just calls TV. So before I get into that, here's my plug for HPV vaccination. So the vast majority of cervical cancer, whether it be squamous or adenohistology, is HPV driven. This is just based on any incidence of cervical pathology. The vaccines work, and extrapolating this can prevent up to 90% of cervix cancer. If we can prevent this, the whole rest of my talk here would be moot, and that would be fantastic. So again, my plug for vaccination. Let's talk about checkpoint inhibition. And so because it's a virally driven cancer, one would think that immunotherapy might be the way to go here. And so this is based on one of the plethora of keynote studies. And then this is using single agent pembrolizumab, fairly heavily pretreated. Here's our waterfall plot. Response rate was 14.6%. But this got approved in cervical cancer based on a response rate of 14.6%, largely because we don't have other treatment options. This is the indication is PD-L1 dependent, but it's based on a combined positivity score greater than 1, of which all these gray bars follow that. And so the vast majority of cervical cancer is CPS greater than 1 positive, so would be a candidate for this. So at least there is some signal of efficacy with checkpoint inhibition. More recently, so if single agent works, can we combine it with chemotherapy? And so combining pembrolizumab with cisplatin and Taxol, with investigators' choice of adding bevacizumab or not. It kind of muddied the water of this trial, and it was one of the things that are discussed a lot as a negative here. But I understood why they did it. They wanted to make this more real life, but basically that it was a fairly large study. 548 women. PFS was very modest, like we often see with immunotherapy, but there was an overall survival benefit at 24 months of about 12%. And so this in the cervical cancer world really made a splash, and was hopeful that by adding immunotherapy earlier, we might have a better benefit. Again, not all these women received bevacizumab, and that is a caveat to this trial, because one would argue that cis-Taxol bev is the standard of care here and has better survival than cis-Taxol by itself. But this is changing standard of care. It is hard to give 4 drugs at once, though. And then the last one I want to talk about is tisotumab. This is our first antibody drug conjugate approved in this space. TV is targeted against tissue factor. Again, just a mechanism of how these ADCs work, right? So the antibody targets tissue factor. It has a payload of toxin. When it binds to the tumor cell, it comes in and then eventually kills the cell. So this, again, similar population had already progressed on chemotherapy, given TV, and then the response rate was 24%. And so if we compare that to single agent pembrolizumab at 14, this is a pretty encouraging response rate. And so approved based on this. As I discussed before, ADCs have an interesting ocular toxicity, and TV has a similar ocular toxicity profile. The label says that they need ophthalmic ophthalmologic exams at baseline and with each cycle. And so that's pretty challenging to do. So I think as we're working this into standard of care, having good ties with ophthalmologists to help us with these exams and with their eye drops and things like that, and really understanding how often they need to be monitored is going to be critical. But it's nice to see improvement in this area. Ongoing trials are really focused on immunotherapy here in cervix cancer, which I think is very rational. We're also seeing some novel kind of radiosensitizers, since radiation is critically important in the initial management of cervical cancer. And then I am just gonna end up with a brief summary. So we talked a lot about PARP inhibitors and ovarian cancer, and I think it's clear that they are an important part of ovarian cancer management. I think that the more subtle questions of when to use it and which populations to use it in are ongoing questions. And then I think these ADCs you're going to see within the next few years. And so I would prepare for those to come onto the scene, and I'm excited to have them as options, particularly in the platinum resistant space. Endometrial cancer, I think we're really going to start understanding these more by their molecular subtypes and seeing more and more trials based on those, and continued efforts in immunotherapy. And then similar cervical cancer, really, I think that the improvements will continue to be in the immunotherapy space. So great, I think I ended like a couple minutes early. I will stop sharing here and take any questions.
And we do have a question in the chat box, Dr. Kaufman.
Sure. I will just read it out loud.
Perfect.
So if a patient has an epithelial ovarian cancer and is BRCA positive, and BRCA is positive, what females and families should be tested? Female adults said linking. Recognizing that the rare ovarian cancer in kids is not usually what lower age tests. Yeah, so great question. So the short answer is they should see a genetic counselor, because there is a lot of psychosocial things that go into this as well, and the genetic counselor can help with this cascade testing. So what you're asking is who in the family needs to be tested, and it will say it's not just females. So the first thing you want to do is test the affected person. So like this, you have your patient with ovarian cancer. She's the one that should be tested because she's the proband, and if she has a BRCA mutation, it gets easier to then test others because you know exactly what mutation you're looking for. And so generally what will happen is, she'll have this specific BRCA mutation, and then they'll contact her family, and generally it's her first and second degree relatives. So siblings, cousins, kids, to ask them if they want to be tested. Remember, BRCA can increase your risk for prostate cancer and pancreatic cancer. So they're also important for male risk, but also if the woman's brother has a BRCA mutation, then you would continue with the cascade testing onto their first and second degree relatives, their kids. And so that you want to identify as many folks that have this mutation as possible. The age is a challenge. So generally we're not testing until kids are over 18. We don't think of these as increasing their risk for pediatric ovarian cancers or really any other pediatric cancers, unless it's biallelic. So homozygosity in BRCA it's a Fanconi anemia gene, right? So you can have leukemias and things, but that's very rare. So generally you're going to wait until adulthood to test these patients. To intervene, really the way we reduce the risk for ovary cancer is risk reducing salpingo-oophorectomy, so taking their tubes and ovaries out. And we generally say doing that after childbearing. So for BRCA1, After childbearing are kind of in their mid-30s. BRCA2, the incidence is a little bit later. So sometimes they can keep their organs a little bit later into actually their early 40s. But that's the time when we're talking about surgical prophylactic removal. You want to think about other things like breast cancer. So, do they go on tamoxifen? Do they, generally they're going to have things like breast MRIs or more rigorous screenings. We talk about prophylactic mastectomies as well. I hope that's helpful. I think that was a lot, but male and female, first and second degree relatives, and when in doubt, just send them to genetic counseling. There's more and more options to do that as telemedicine as well. Were there other questions?
Dr. Kaufman, since you brought up the HPV vaccine, I recently heard a speaker say that they're even pushing the age limit to, I believe, mid-40s now. Are we seeing any data from the effectiveness of such late vaccination?
Yeah, so certainly the goal of the vaccination age would be to vaccinate before we're exposed. And the data in terms of age is that 80 to 90%, maybe even more, have been exposed by their early 20s. Hence the like 14 age. The data is immature right now to know if we vaccinate later what that does. And there's some argument to say vaccination can actually enhance the immune clearance of HPV. So rather than prevent it, helping you clear it, because that's really the problem. Most people are exposed to it. Most people clear it. It's those that don't clear it and have persistent infection and integration of some of those viral genes into the generally squamous epithelium that eventually transforms. So there's some thought to say, vaccination can actually help trigger that immune response. And there are ongoing trials to actually do that with people that actually have cervical cancer too, as a way to enhance immune therapy to the cancer itself. So hopefully we'll get some more data to help guide that. Great question though.
Great. Do we have any other questions from our audience? Okay. Well, seeing none, Dr. Kaufman, thank you so much for a very interesting talk this evening. It was very good information.
Yeah, I'm always happy to talk about it. I feel like, especially as medical oncologists, we don't always get a whole lot of exposure to the gyn-onc world. So, and if anyone ever has questions or runs across a patient, I'm always more than happy to help. So thanks for inviting me to speak. It was my pleasure.
Thank you so much, Dr. Kaufman. Appreciate sharing your time and expertise with us tonight.
All right, thanks.
Thank you. All right. So with that, we'll move on to our next segment, which we want to thank our industry partners for their support. So we'll take a quick 10-minute break to allow folks on the call to visit their booths. The representatives are at each of the booths and can speak with you live. So just remember that we are competing for a $100 gift card if you're able to send me 7 unique codes from the exhibitor booths tonight. So I'll start the clock, and I hope that you're able to visit with all of them and thank them for their support. So I hope that you've had a chance to visit the exhibitors for tonight. Just a few announcements before we end the session. So the Nebraska Oncology Society will be hosting one more evening speaker series on November 15th, focused on survivorship. And then we are looking towards that end of January, end of February dates for the Midwest San Antonio Breast Cancer Symposium review. So we'll keep you guys updated on those dates as well. Just also want to, let you guys know that we have been involved in advocacy this 2022 legislative session. We partnered with the Nebraska Hospital Association in order to support a white bagging bill introduced by Senator Bostar that actually was voted out of committee. So we anticipate more movement on that this coming year. And we'll also be working with Senator Bostar of Lincoln to ensure that lung cancer screening will have coverage based on the new guidelines rather than the old ones. And so we'll keep you guys posted on those notices. And finally, also want to encourage everyone to support the one physician who is running for the legislature, and that's Dr. Patrick Hotovy out of the York Seward area. So if you have friends or family or colleagues who live or work in that area, just encourage them to support Dr. Hotovy. It's really important to have a physician in the legislature who understands a lot of the things that most of our legislators just don't, just due to their lack of medical training. And so just to kind of help put things in perspective, the last time we had a physician in office was, I believe, 2008. And without his leadership, Nebraska would not have an Indoor Clean Air Act at this time. And so, we do appreciate whatever we can do and whatever our members can do in order to help support causes that help protect the health of Nebraskans and help protect patient safety and help protect physicians as well. And so with that, I want to thank everyone for participating tonight. You can claim your CME at our event website at nebraskaoncology.org/events. And I hope that you will join us for the rest of our evening speaker events in 2022 and look forward to our 2023 programming. And as always, if you have any questions, feel free to reach out to me or to Tanya, and we'll be able to direct you. So have a great rest of your night and appreciate all of you here.
Thanks, Carmen. Have a good night.
Thank you. You too.